Welcome back to the deep dive. Today, we are putting on our scrubs, metaphorically speaking, and stepping into the shoes of a medical detective. We've got a stack of notes here detailing a really fascinating case study that, it just perfectly illustrates the art of diagnosis.
It really does.
It's not just about looking at a chart. It's about reading the subtle clues a patient brings into the room. Clues that sometimes they don't even realize they're revealing.
Exactly. It's often said that the patient will tell you the diagnosis if you listen long enough, but sometimes you have to know exactly which questions to ask to unlock that information.
Right.
And today's case is a perfect example of how a seemingly harmless complaint can unravel a much more complex and high-stakes biological reality.
So let's introduce our subject. The medical notes refer to her as Mrs. X. She's a 24-year-old woman from Delhi, specifically from an urban background, lower middle socioeconomic class.
Okay.
And this is a detail I want you to file away for later because it becomes the key to a really clever piece of detective work. She works as a tailor.
Ah, the occupation.
Yeah.
That's actually going to be quite important in the history taking. It gives us a functional baseline. But let's start with why she even walked into the clinic in the first place.
Right. So she presents with a swelling in her neck. And this isn't something that just popped up overnight.
No, not at all.
She told the doctors she noticed this 6 years ago. It's in the lower midline region of her neck.
6 years? That's a long time. In the world of, oncology and tumors, time is a massive variable. Usually a 6-year history suggests something slow growing, often benign.
So not immediately scary.
Exactly. If something were an aggressive cancer, you'd expect dramatic changes much, much sooner.
Yeah.
So right off the bat, the timeline is kind of lulling the doctors into a false sense of security.
That's what makes it so tricky. She comes in and basically says, I have this lump and I've had it forever. But here is where the plot thickens.
Okay.
For the last year, she's had difficulty breathing, but only when she's lying down.
That is a classic mechanical symptom. It's called orthopnea. It suggests the mass is large enough or positioned in such a way that gravity causes it to compress the trachea, the windpipe, when she's supine.
So when she stands up, it's fine.
Yeah, when she stands up, gravity pulls the mass down and opens the airway. But lying flat, it crushes the pipe. It's a sign that this isn't just a cosmetic issue anymore. It's physically infringing on vital structures.
But, aside from that breathing issue, she's remarkably symptom-free. She reports no pain, no difficulty swallowing. Her voice hasn't changed.
Nothing.
And she claims the swelling hasn't even grown that rapidly.
And that's the initial puzzle. You have a 24-year-old with a painless mass. Her past medical history is unremarkable. No comorbidities, no crazy family history that she volunteers initially. On the surface, she just looks like a stable patient with a simple goiter.
Okay, let's unpack this, because the difference between a good doctor and a great doctor is often in this detective work phase, the history taking. You have this patient saying, I'm fine, just this lump. How do you dig deeper?
Well, you have to move past the I'm fine and start hunting for systemic clues. In thyroid cases, we always have to rule out functional issues first. The thyroid is it's the engine of the body.
Right.
So is the engine running too hot hyperthyroidism or too cold hypothyroidism? So even if she says she feels good, we have to ask, are you intolerant to heat or cold? Have you lost or gained weight unexpectedly?
And the notes mention checking for psychiatric issues as a symptom. That seems like a bit of a leap.
It does, doesn't it? But thyroid imbalances can manifest as anxiety, depression, or even mania because thyroid hormones interact directly with the brain. It's part of the comprehensive screening. But let's go back to that detail you mentioned earlier. She's a tailor.
Yes, this is one of my favorite parts of this file. The doctor asks her about her ability to thread a needle. Why specifically that?
This is a brilliant example of contextual history taking. The doctor is looking for tremors. Fine, shaking in the hand. Tremors are a classic sign of hyperthyroidism or thyrotoxicosis. But here's the thing. If you ask a patient, do you have tremors? They might say no, because they don't know what you mean or they haven't noticed.
They don't have a frame of reference.
Exactly. But asking a tailor, can you still thread a needle easily, gives you a functional, real-world answer.
That is so smart. It's translating the medical symptom into the patient's actual daily life.
Right. If she says, actually, I've been struggling with that lately, you've just uncovered a neurological symptom of thyroid disease. They also checked her handwriting for changes, looking for something called micrographia, or a shaky script.
And in her case,
In Mrs. X's case, she could still thread the needle. That told the doctors her thyroid wasn't overactive, she was euthyroid.
which paradoxically might be more worrying because it means the lump isn't just the gland working too hard. It's a growth.
It's a structural problem, not a functional one.
Now, even though Mrs. X claimed her voice hadn't changed, the source material emphasizes that doctors listen for persistently worsening voice quality. Why are they so suspicious if she says she sounds fine?
Because patients adapt. A slow change in voice might not be noticeable to them, but to a trained ear, a rough or breathy quality suggests something dangerous.
How so?
The nerves that control your voice box, the recurrent laryngeal nerves, run right next to the thyroid. If a tumor is benign, it usually just pushes the nerve aside, but if it's malignant, it invades the nerve, it eats into it.
Right.
So if the voice is changing, that really pushes the diagnosis toward cancer.
Okay, and before we touch the patient, there's one more history aspect. Family history. We mentioned hers was unremarkable initially, but what are the doctors specifically hunting for here?
They are hunting for MEN,
Men.
M-E-N, multiple endocrine neoplasia syndromes, specifically MNN2A and MN2B. These are genetic conditions where you see clusters of tumors in different glands. So if a patient has a family history of thyroid issues, adrenal issues, or parathyroid issues, it raises a massive red flag for a specific kind of cancer called medullary thyroid cancer. It changes the entire risk profile from maybe a cyst to probably genetic cancer.
So we've grilled Mrs. X, we've asked about threading needles and family trees. Now we move to the physical exam, reading the body.
Right, and the general assessment is key. Is she anxious? Is she hydrated? Mrs. X appears stable, conscious, cooperative. But then we look at the neck.
And the notes here are vivid. We aren't talking about some pea-sized lump. This swelling is approximately 7 by 5 centimeters.
That is substantial. 7 by 5 centimeters is roughly the size of a large lemon or maybe a small orange. Imagine that sitting in the lower part of your neck.
Wow. Okay, so she has a lemon-sized lump in the lower midline of her neck.
And crucially, the exam notes it is spheroidal or globular. It's firm, it has a smooth surface, and it has well-defined margins.
Really sounds good, right? Smooth usually means safe.
Often, yes. Cancers tend to be hard, craggy, irregular. This feels smooth, which again kind of leans into that benign narrative. But the most important test in a neck exam is watching it move.
It says it moves with deglutition. That's a fancy word for swallowing, correct?
Correct. When you swallow, your larynx, your voice box moves up. Since the thyroid gland is attached to the larynx by fascia, it moves up too.
So it's a giveaway.
It's a dead giveaway. If a neck lump moves with swallowing, it confirms the mass is attached to or is part of the thyroid. If it stayed still, it might be a lymph node or a cyst unrelated to the gland. So we know for sure it's thyroid.
It also mentions it extends behind the sternocleidomastoid muscle on both sides. That's that big muscle that pops out when you turn your head.
Which just indicates the breadth of this mass. It's widening out, tucking itself behind the musculature. But up until this point in the exam, you could argue this is just a very large, benign goiter. It's smooth, it moves, it's been there for 6 years.
But here's where it gets really interesting and scary. The red flag.
Yes. This is a pivot point.
During the exam, they find something else. A palpable 1 centimeter firm lymph node on the left side at level 3.
This changes everything.
Why does one tiny 1 centimeter bump matter more than the 7 centimeter lemon?
Because a benign thyroid swelling, a simple goiter, does not typically spread to the lymph nodes. It stays contained. Finding a firm, palpable lymph node in the neck, specifically at level 3, which is the mid-jugular region, suggests metastasis.
Predict.
It suggests the disease has left the thyroid and is traveling through the lymphatic system.
So the whole narrative shifts immediately from annoying lump to cancer.
It has to. In fact, there's a critique in the source material about how this case was summarized. The initial impression in the notes was just midline, non-toxic, solitary thyroid nodule.
That sounds pretty mild.
It sounds mild, but the critique argues that is dangerous phrasing. Given her age, she's only 24, and the presence of that lymph node, the clinical impression must be malignancy until proven otherwise. You just cannot dismiss that node.
That's a heavy realization. So we have a high suspicion of cancer. Now we need proof. This leads us to the diagnosis phase and the triple assessment.
The triple assessment, it's the gold standard in oncology for this region. The three-legged stool, clinical exam, which we just did, high-resolution ultrasound, and FNAC.
FNAC.
Fine needle aspiration cytology. You need all three to be sure. If you skip one, the stool falls over.
Okay, let's look at the ultrasound. It's not just taking a picture, is it? They're looking for specific characteristics.
Absolutely. High-resolution ultrasound looks for 5 specific features that suggest cancer, like microcalcifications, little specks of calcium, or irregular margins. But they also use Doppler.
Like a radar.
Similar concept. Doppler ultrasound looks at blood flow vascularity. Tumors are hungry, they need blood to grow, so they build these chaotic, messy networks of blood vessels.
They're looking for traffic jams in the blood flow.
Exactly. They measure something called the resistance index. Essentially, malignancies often have this chaotic, high-resistance blood flow pattern compared to a simple toxic goiter, which might have high flow but low resistance. It helps differentiate what this mass is made of biologically.
And then the needle. FNAC.
This is where they take a tiny sample of cells from the mass to look at them under a microscope. It's the only way to know for sure what those cells are doing.
The notes mentioned the Bethesda system. What is that?
It's a standardized reporting system for thyroid cytology. It ranges from category 1, which is inconclusive, all the way to category 6, which is malignant. It stops doctors from using vague terms.
So everyone's on the same page.
Exactly. You have to categorize the risk so the surgeon knows exactly what to do.
And for Mrs. X, what was the verdict?
The FNAC confirmed it. Category 6, medullary carcinoma.
Medullary carcinoma. Now I know there are different types of thyroid cancer. We hear about papillary cancer a lot. Is this the good kind or the bad kind?
Well, no cancer is good, but medullary is specific. It's rarer than papillary, and it arises from a completely different cell type. It comes from the parafollicular C cells of the thyroid, not the main thyroid cells. And this brings us right back to that genetic link we talked about earlier.
The MEN syndromes.
Exactly. Because it is medullary carcinoma, the doctors immediately have to pivot. They can't just schedule surgery yet. They have to check for a pheochromocytoma. It's a tumor of the adrenal glands, which sit on top of your kidneys. Remember, MAN syndromes cause clusters of tumors.
Oh, right.
So if Mrs. X has a genetic condition, she might have a thyroid tumor. AD, an adrenal tumor.
Why does that matter right now? Can't they just deal with the neck first?
This is critical. A pheochromocytoma releases massive amounts of adrenaline. It's an adrenaline factory. If you put a patient under anesthesia and cut into them without knowing they have this adrenal tumor,
Oh, no.
the stress of surgery can trigger a lethal hypertensive crisis.
So the anesthesia itself could trigger the adrenal tumor.
Yes. Their blood pressure goes through the roof, leading to a stroke or cardiac arrest right there on the operating table.
So diagnosing the neck lump actually requires looking at the kidneys first to make sure surgery is even safe. That is wild.
Correct. They have to do an ultrasound of the abdomen and check blood levels of calcitonin and CEA, which are markers for this specific cancer. It's a safety check that saves lives. It's a perfect example of treating the whole patient, not just the lump.
That connects the dots on why the whole body approach is so vital.
Okay, so let's assume she's cleared for surgery, her adrenals are fine. What's the strategy here? The source says total thyroidectomy.
Yes, the entire thyroid gland has to go. You can't leave any tissue behind.
And they don't stop there. They also did a bilateral central compartment lymph node resection and a left-sided modified radical dissection. That sounds incredibly aggressive. They are really excavating the neck.
It is, and for very good reason.
Yeah.
Medullary thyroid cancer is notorious for early lymph node metastasis. Remember that one little node we felt?
There are likely microscopic cells and others that we can't feel or see on an ultrasound yet.
So they're just cleaning house.
They are. And here is the kicker. Medullary cancer does not respond well to radioactive iodine or chemotherapy.
Oh, really? I always thought radioactive iodine was the standard treatment for thyroid cancer.
It is, but for papillary and follicular cancers, those cells suck up iodine, so we can feed them radioactive iodine, and they destroy themselves. It's like a magic bullet.
But medullary cells?
They don't absorb iodine, they ignore it completely.
So you don't have a backup plan?
Exactly. Surgery is your only real shot at a cure. You have to get it all out the first time. You leave cancer behind, you can't just mop it up with a pill later on.
That explains the prophylactic dissection the notes mention. Even if the other lymph nodes look totally normal, they take them out anyway.
Precisely. In the central compartment of the neck, even if the nodes look clear to the naked eye, the protocol for medullary cancer is to remove them. It's better to be aggressive now than to have the cancer return in a year when it's much harder to operate because of scar tissue.
The source also briefly compares this to papillary carcinoma regarding calcium. What's the distinction there?
It's an interesting diagnostic nuance. If a patient had papillary cancer and high calcium levels, you'd suspect they might also have a parathyroid issue like hyperplasia or an adenoma. But with medullary, high calcium isn't the primary marker we look for. We're looking for calcitonin. It's just another example of how the specific type of cancer dictates what other blood tests you need to run.
So Mrs. X undergoes this major surgery. Her thyroid is gone, the lymph nodes are gone. What happens next? How do we know she's okay?
Monitoring. The source mentions using thyroglobulin as a marker to track the patient, although for medullary specifically, we'd really be watching those calcitonin levels we mentioned.
Right.
Since the cells that make calcitonin are now gone, the level in her blood should be effectively 0.
And if it starts rising,
Then we know there are cells lurking somewhere, maybe in a distant lymph node or elsewhere, but because they did that aggressive surgery, she has the best possible chance.
it's a lifelong relationship with her endocrinologist at that point.
It is, but it's a life she gets to live.
So what does this all mean for us? I mean, we started with young Taylor, who just had a lump in her neck.
And we ended up navigating a complex genetic landscape, adrenal checks, and radical surgery.
It really highlights the danger of the silent symptom. I mean, she had no pain. That just sticks with me.
That's the biggest takeaway for me. Pain is actually a late symptom in many cancers, or sometimes it never appears at all. We are conditioned to think pain equals problem. But here, the fact that the lump was hard, fixed, and associated with a lymph node was far more alarming than pain would have been.
And the importance of that triple assessment. You can't just guess. You need the exam, the image, and the cells.
Absolutely. The clinical impression is just a hypothesis. The triple assessment is the proof. You have to prove it before you cut.
It's just fascinating how interconnected the body is. You pull on a thread in the neck, pun intended, for our Taylor, and you find yourself checking the adrenal glands down in the abdomen.
That's the beauty and the terror of medicine. Nothing exists in isolation.
I want to leave our listeners with a thought. We talked about how the doctor asked about threading a needle to check for tremors. It makes you wonder, what other daily habits do we have that act as health barometers?
That's a great question. We do things on autopilot every single day that require complex biology.
Yeah, maybe the fact that you stumble a little bit when you put on your socks, or that you need to turn the volume up on the TV just a notch higher than last year.
Or that your handwriting has become tiny, or you're drinking way more water than usual. Those tiny functional changes are often the first whispers of biology telling us something is wrong.
Exactly. So pay attention to the little things. It might just be the most important clues you have. Thanks for diving in with us today.
A pleasure as always.
Catch you on the next deep dive.